Thank you so much. We are ready to move to our next talk in this session. Okay, so it is my pleasure to introduce Audrey Kaufman, presenting our next talk. Yes, big round of applause. Uh, Audrey is a part of our team at TIMI. She works in the clinical trials units led by Dr. Venkatesh Mani. And she's an image analyst and research scientist, and she's going to talk to us about the quantification of pulmonary thrombi using computed tomography. So thank you very much. Looking forward to the talk.
Thank you. Thank you. My presentation today is of our study entitled Effect of Acquisition and Reconstruction Parameters on Quantification of Thrombus Volume in Pulmonary Embolism using CT Pulmonary Angiography, Implications for Multi-Center Studies. Venous thromboembolism, VTE, represents the combined disease states of deep venous thrombosis, DVT, and pulmonary embolism, PE. A clot, which forms deep in a deep vein, hold on, I'll just try to, here, usually in the leg or pelvis, breaks free, flows up towards the heart, and becomes jarred as a PE within the branches of the pulmonary artery. PE is the most significant sequela of DVT and occurs in more than a third of DVT patients. In the US, there is an average annual incidence of over 275,000 new cases of VTE combined among whites of European origin and African Americans. VTE is predominantly a disease of older age, with males slightly more affected than females. Emboli to the lungs cause physical obstruction of the pulmonary arteries, causing a pathophysiologic cascade resulting in varying degrees of pulmonary and cardiovascular distress. This illustrates, nicely how an embolus blocks the vessels beyond, and an infarct can occur in the lungs. PE has a high mortality rate. The 2-week and 3-month post-diagnosis all-cause mortality rate was found to be 11.4% and 17.4% respectively. Risk of mortality in PE rests upon multiple factors, including clinical findings of shock and hypotension, and elevated markers of right ventricular dysfunction and myocardial injury. Here's a specimen photographed at autopsy demonstrating a large saddle embolus within the right and left pulmonary arteries. Clot burden alone is not a principal marker in clinical risk stratification. However, CT, pulmonary angiography, CTPA, is a commonly used diagnostic tool which has been shown to help with risk stratification in PE. Objectively measuring thrombus volume from CTPA data can be particularly useful to evaluate the efficacy of treatments for PE. Indeed, clinical pharmaceutical trials of drugs such as thrombolytics rely upon objective measures, including total thrombus volume, to assess drug effectiveness and potency, and to help determine the optimal duration of therapy. Quantifying clot burden with CTPA requires segmentation of emboli from non-thrombotic contrast-enhanced blood within the pulmonary vasculature and computation of clot volume. Semi-automated region-growing algorithms can be used for this purpose. The inter- and intra-observer reliability of the assessment of such an algorithm has been tested in data from a single center using one fixed CTA imaging protocol. However, this type of study has not been implemented in a multi-center setting. Furthermore, the effects of various imaging parameters on the quantification of PE measurements has not been studied extensively. The purpose of this study is thus twofold. The first purpose is to examine the effects of varying CT image acquisition and reconstruction parameters on the quantification of clot volumes in vitro. The second purpose is to evaluate the reproducibility of in vivo PE data obtained in a multi-center setting where the CT scanners vary by site, as do the acquisition and reconstruction parameters. The study was performed using anonymized data in conformance with HIPAA and IRB regulations. And again, the study was performed in 2 parts, so we will start with the in vitro. We designed and scanned a 10 blood clot phantom, shown here. All the clots are numbered here. 10 clots of varying sizes were created in test tubes by allowing venous blood to coagulate by exposure to air. The purpose of making the 10 clots was to replicate various size emboli found in vivo. A gold standard volume for each clot was measured using the water displacement method in graduated cylinders with multiple repetitions and a mean calculated. The clots were imaged in Falcon tubes and test tubes of varying diameters to replicate pulmonary vessels. The tubes were filled with diluted solution of IsoVue 370 to simulate the typical Hounsfield units of blood in the pulmonary arteries following injection of iodinated contrast material. All 10 clots in the tubes were scanned simultaneously on a Siemens Force dual energy CT scanner using various image acquisition and reconstruction parameters, all listed here. So there were 5 different energy levels, 4 slice thicknesses, 3 pitch, and a Siemens advanced modeled iterative reconstruction that was either on or off, overall yielding the following imaging permutations. So that was for a total of 120 scans. Here again is the photograph of the 10 clots, but now we have the volume rendered CT image here, and the clots seen in 3 different coronal planes. All the clots are visible. You can see them in it's a lower density inside the tube. One image analyst identified the clots within each of the 120 acquisitions and measured the volume using a semi-automated region growing algorithm implemented in the FDA-approved Siemens SynGO-VIA image analysis platform. A total of 1,200 volume measurements were made. A mixed model statistical method was used with pitch and admire set as discrete variables and slice thickness and energy as continuous factors. Clots 1 through 10 were set as random factors. Okay, this is the in vitro region growing of the clots as seen on the viewing workstation. The segmentation and volumetric quantification of the emboli are made right here. To acquire the readings, the cursor is placed on the clot and pressed, the mouse is pressed and held so it grows to grab regions of adjacent similar density. So this is clot 10 as seen in 3 views, and you happen to see clot 5 here. And here's a list of all the other clots from the same permutation of variables from the same scan. Graphs were prepared to assess the effects of various parameters of the CT acquired volume as compared to that of the gold standard volume. Overall, the statistical analysis of the raw clot volume data revealed no statistical significance among the levels of the fixed factors of pitch and admire, nor for the continuous factors of energy or slice thickness. And here are the box plots for one sample clot 8, which look similar to the plots of the other clots and show no significant differences between the tested parameters as they compare to the gold standard. Limitations of the in vitro portion of the study included not using a human thorax phantom, which would have introduced a varying degree of scatter radiation that may have possibly affected the measurement accuracy. An additional limitation involves some degree of imprecision with the water displacement method for the gold standard volume. Also, although we applied multiple variables and used a range of clot sizes, not all variables, additional reconstruction methods, could have been evaluated. So overall, our analysis showed varying the CTPA image acquisition parameters and using iterative reconstruction had no significant impact on clot volume quantification. Thus, measurements of clot volumes using semi-automated analysis may be robust across a range of image acquisition and reconstruction parameters that typically may be used at various imaging centers in a multi-center study. Okay, now for the in vivo portion of the study, again, the purpose of which was to assess the reproducibility of clot volume analysis using CTPA to affect its potential use in multi-center clinical trials. CTPA data was acquired from 23 scanners from 18 different centers using each site's standard image acquisition protocol for PE. In a total, 4 scanner manufacturers with 15 different models were represented. As well, there was a wide range of the KVPs used and the number and thickness of the slices. The data was completely anonymized and no patient demographic information was available for us. For the in vivo measurements, embolus volume was a measured parameter and the endpoint was total thrombus volume per each individual. 2 experienced image analysts performed the in vivo study and assessed each patient for the presence of emboli within the pulmonary arterial tree, from the main pulmonary artery extending and including the segmental arteries bilaterally. An embolus appears as a filling defect of soft tissue density in the otherwise contrast-enhanced pulmonary arteries. This is a, normal CTPA in 3 orthogonal views, the axial, coronal, and sagittal, and the pulmonary arteries are seen very well, fully enhanced with contrast, and there's no evidence of filling defects. This case, on the other hand, shows a saddle embolus in the 3 views. The filling defects represent the embolus. Seen here, the saddle embolus going into the truncus anterior and the interlobar artery on the right, and then on the left side down towards the lingula and the lower lobe. Each separate embolus was analyzed using the same region growing technique as was used in the in vitro study. The 2 independent observers were blinded to each other's interpretations when computing the clot volumes for each of the data sets to determine the inter-observer reproducibility of the analysis. One reader repeated the analysis a second time to establish intra-reader reproducibility. Okay, here is region growing on the viewer at the workstation. Above, I know it's small here, but there is an embolus identified posterior here in the interlobar artery on the left. And then, down here, it's in green. It's hard to see, but let's see, we have okay. So here is region growing on the viewer with a PE, and the trunk is also anterior, going to the interlobar artery, and it grows as you press on it, and the analyst adds and subtracts areas as needed to represent the volume as best possible. These are the results with the range found by each analyst of 0 to 11 emboli per patient, and the ranges of clot volumes are also noted here. The plots are here with ICC and Bland-Altman analyses showing excellent correlation and no bias. Here above is the inter-reader reproducibility, and down below the intra-reader reproducibility. The in vivo study was limited by a couple of factors. First, a small number of subjects were evaluated at a small number of sites. Second, the intra-reader variability analysis may have been affected by recall bias, as there was a short interval of only 2 weeks between the 2 reads. The challenges faced in a multi-center study such as ours include the variety of imaging systems, models, and protocols used, and the resultant variability in the data acquisition. But even with the variability inherent in the multi-center data acquisition and reconstruction, the image analysis methodology employed in our study is reproducible and therefore suitable in multi-center settings. This study furthers the body of knowledge regarding assessment of PE by quantifiable metrics and the ability to evaluate these metrics when they are acquired in a multi-center setting. And here is just, here's a movie of the evolution of pulmonary emboli. You will see a multiplanar reformatted 3D image showing the volume masked clots in pink. The overlying structures are removed so we can see the emboli better. And there are bilateral emboli, and at first they're seen at baseline here. And this is at patient presentation. And then the patient is given a medication, a thrombolytic of sorts, and visible improvement is noted in the size of the clots following the infusion. Okay, and that is it. No, yeah, okay. Okay, so I'd like to thank all my coworkers with special gratitude to Dr. Manny and Sarah Yu Wong and Allison Pruzan for all their help with the study. And a big thank you to Catherine Ma, if she's here, and Dahlia Kaufman for their help preparing my presentation. Thank you.
Excellent. Thank you so much, Audrey, for showcasing this very important work from our institute. Any questions? Just like, okay. So I guess very quickly, I think, let me give you your certificate for our appreciation.